Oops. All right, there you
go. Hey, Dr. Armstrong here. Hope you had a good spring break and are ready to roll this week. I'd like to talk to you a little bit about Chapter 5 today, the shoulder joint. Just let me give you a few introductory remarks in regard to Chapter 5 and actually in regard to the next several chapters. You're going to see a number of bones that are listed and illustrated in each chapter. And you do need to obviously know those bones, and it'd be helpful for you to know all the landmarks that are mentioned. Know what type of joint is articulated. In Chapter 5, for example, know the difference between the shoulder girdle and the hip girdle. You should be able to learn the muscles by sight, by their movement, by their name, and also become familiar with the proximal and distal attachments. Now, there is one school of thought in terms of teaching kinesiology of memorizing origin and insertion of muscles. There's nothing wrong with that. However, we don't do that at this point, and you'll have opportunity for that, especially given the nature of this class where it's an open resource quiz and exam. Well, let's talk about some of the muscles that are in Chapter 5 and some of the significant features of them. We'll start with the pectoralis major. Note that there's a very long proximal attachment all the way from the middle of the clavicle down to the 7th rib. Now, what's interesting about this is that the purpose of training will determine the type of exercise you do in terms of the pectoralis major. For example, the upper fibers of the pectoralis would be good for training for example, the shot put, where you are pushing up and out. You're going to use the upper fibers, therefore you probably would be doing an incline bench. If you're doing something for the lower fibers of the pec, then you probably are doing a prone bench, and it could be an activity such as boxing. Okay? The trapezius. Now, like the pectoralis major, the proximal attachment's very long, from the cervical vertebrae all the way through the thoracic vertebrae. The upper fibers elevate the scapula, the middle fibers retract, and the lower fibers depress. And together they effectively rotate the arm. The rhomboid. Now notice the type of fiber of the rhomboid. They're diagonal, they're short, so you have more fibers per square inch. It's a very strong muscle. It's mostly not palpable, although you'll find differing sources. One will say, well, you can palpate it along the medial border when it's contracted, but for the most part, it's covered up by the trapezius. Now, it's interesting, note when you hang from a bar, the scapula would be protracted. And when you initiate the up phase of the pull-up, the rhomboids will adduct and retract the scapula. And I believe there's a picture, an illustration in one of the the PowerPoint slides for this particular chapter that indicate that. The latissimus dorsi. Now, exercising the lats gives the individual that tapered look. Notice that the distal attachment comes around the medial side of the humerus and attaches to the anterior side. So this would give you a hint as to what the movement would be. Going back to your understanding of the fact that when a muscle contracts, it pulls equally toward both ends. But then, since the one end is more, I like to use the word anchored, it's going to usually cause the distal attachment to move. So the distal attachment will enable medial rotation of the arm as well as shoulder abduction. The deltoid. Notice that with the deltoid you have an anterior proximal attachment that flexes and medially rotates the arm. You have a middle proximal attachment that abducts the arm, and then the posterior proximal attachment, which initiates arm extension and lateral rotation. So the best way to examine this is just to palpate your own deltoid and to move it around so that if I'm extending the arm, I can feel the anterior fibers, and as I move my arm around and abduct, then I can feel the middle fibers, and as I come around here to the back as I extend, I can feel the back fibers as well. Now, let's talk a little bit about the rotator cuff. The rotator cuff is, there are 4 muscles in the rotator cuff, although we usually count the infraspinatus and teres minor together. But let's talk a little bit about each one. The subscapularis. The entire anterior surface of the scapula is the proximal attachment, and then the lesser tubercle of the humerus is the distal attachment, and that causes medial rotation of the arm. Okay, so medial rotation, medial is toward the midpoint, whereas the infraspinatus and teres minor, the proximal attachment covers the entire posterior surface of the scapula, and then the distal attachment is on the greater tubercle of the humerus. So this causes lateral rotation. So can you begin to see how the rotator cuff is for protection? You've got, when you have too much rotation possibly going one way, it checks with the other. Then you have the supraspinatus. The supraspinatus is a very, very thin little muscle, and if we had a scapula here, a loose bone, we're able to look down the top, along the top of the supraspinatus groove. This is where it sits. It is used as an abductor of the arm, but you can see how the abduction happens mostly with the deltoid, but the supraspinatus does assist. Now, one thing that's interesting about this muscle is that it is a 1:20 ratio muscle, meaning that in order for it to initiate some type of a movement, to lift a weight, so to speak, it has to work 20 times greater than that weight. So it's really more of a stabilizer of the humeral head in the glenoid cavity, and this is one of the main functions of the entire rotator cuff, is to keep that the head of the humerus in the glenoid fossa to prevent any kind of dislocation. Now, the supraspinatus is the most frequently damaged rotator cuff muscle. It's the one that's responsible for when you hear about impingement of the shoulder. This is usually when you have an inflamed and swollen bursa, and there's only so much room in the fossa along here, the groove in the top of the scapula. And when you have this swollen and inflamed bursa, it causes what we call impingement. pain, basically. And those of you who are in athletic training know that there's one very simple test they talk about. I believe it's the empty bucket, where you bring your arm here and you point your thumb down, and then you are pressing up against resistance, and pain would indicate some type of problem with usually the supraspinatus. When there is impingement in the supraspinatus, one of the things that can be done, if the doctor deems it necessary, is to go in surgically and shave a little bit of the acromion down, actually to make more room for the muscle. Now, with most muscle injuries that involve swelling and inflammation, hopefully most of those can be curtailed just through rest. But when you have a more serious injury, this is when a more invasive type of surgery would be involved. Now, here are some suggestions for studying Chapter 5. It would be helpful for you to have access to an articulated skeleton and or some loose bones. Now, there are a couple of places I know that in the department that have the articulated skeleton. Those of you who are, again, in athletic training obviously work with the skeleton all the time. And there are a lot of loose bones. When I was there, I had a lot of loose bones that I would use from time to time in class, basically a whole file drawer full of them. And I can't imagine that they're not there somewhere. I would start with April. She may have inherited those bones, or you may go to Dr. Thompson. He may know where they are. But they're really helpful in especially learning landmarks. And for example, if you were asked to identify from a position of a femur or humerus, whether it was anterior, posterior, whether it was left or right, it can be very helpful for you. Especially with the articulated skeleton, you can move the bones within the fundamental movements like flexion, extension, etc. And it's helpful then to try to name the muscles and the attachments for review. Now, those of you who are spend some time in the weight room, especially with some of the machines and the newer machines, you'll notice that a lot of them now have illustrations somewhere on the frame, usually showing a picture, an illustration of a person doing the exercise. And a lot of times they'll have the muscle area that's affected shaded in red. And these can be really helpful, even in review, if you're trying to determine, okay, what area of the body does this isolate? And this brings up another point that we have talked about the fact that there's a difference between using the free weights and using the machines. And one of those is that you usually can put up more weight with the machine than with the free weight, because with the free weight you are worrying about balancing it any number of ways, but it's more true to life in terms of a sport. Whereas with the machine, because it's usually in terms of a pulley system, now you'll find some of the most modern weight machines, for example, for benching, have the actual bar on a track that is going up and down, and it has hooks along the way, so you really can't drop it on yourself, and you really can't take it out of line, and so all you have to do is push. And my point here is that this tends to isolate individual muscles or sometimes muscle groups. So if you're benching with a machine like this, it's not going to be working on too many other muscles other than the pec and as well as the tricep. So one last thing I would suggest to you as we go through these next chapters 5 through 11, and especially as we study the rotator cuff, and then when we get into the knee, I would suggest, if you have not already done this, that you go to YouTube and look up videos on surgeries. Now, they can be really fascinating once you get over, if you have a phobia about blood or anything. If you get over that, these could be really fascinating videos, especially with the rotator cuff as well as knee surgery. So I would suggest that you take a look at some of those. Again, if you have questions for me, do not hesitate to email or possibly text. And in terms of your paper, you all now have topics that are approved, and the next step will be putting together an outline. And I would suggest that if you have not already done so, look at the sample outline that I've provided on Canvas, and it includes all the elements that I'm looking for. I don't want you to copy the framework, but it gives you an idea as to what I'm looking for in this particular outline. Thanks so much, and I'll be talking with you again soon.